Thank you and good morning. I have one question to start with. Curing and controlling lung cancer, can it be done? Every time I ask this is the response. Stop, stop, stop. I'm going to pee in my pants. I'll ask it again. Curing and controlling lung cancer, can it be done? No, I mean it, Walker. This time I'm really going to pee in my pants and I'm wearing khakis. Every talk of lung cancer goes through the statistics. 220,000 lung cancers a year, 160,000 deaths in our country. That's 438 a day. That's 18 during this hour. In the state of North Carolina, it's 5,600 lung cancer deaths. It equals colorectal, prostate, breast cancer, pancreas, and leukemia. Okay, no, everybody so-so, no big deal. But what if? What if every day a Boeing 747 dropped from the sky containing 438 people? Don't you think by the third day something would be done? There would not be a 747 that went into the sky. Yet in lung cancer, 438 patients die every day. And what do? Never smoking lung cancer is the sixth leading cause of cancer death in our country. And that's 20,000 deaths per year. And for those of us that fly out of PGV on the dash bombardier in that back middle seat has the best leg room there is, that's two of those falling from the sky every day from PGV. But what do we do about it? We are internists and we think. And what we think determines what we do. If we do not think differently, we're never going to do differently. And what people think about lung cancer is blame, shame, and despair. A study looked at that from caregivers, patients, the public, and even providers. 8% equated those words with breast cancer, but 70% equated those words with lung cancer. And to be honest, there's a diagnostic and therapeutic nihilism regarding lung cancer among internists, among pulmonologists, and to be honest, even among medical oncologists. And today I want to outline and review several great advances that could be done to help control and cure lung cancer, as well as the therapeutic steps that are being done. But what oncologists tend to do, we really are working in vain. Medical oncologists, we like to focus on stage 4 lung cancer. Well, the chances of curing that are real, but very, very slim. We all get in our own little world and we labor in vain and do the same thing over and over again. There are 3 potential great changes that could impact the cure of lung cancer. First and foremost is tobacco cessation. Only 15% of smokers get lung cancer. So smoking is not the cause of lung cancer, it is a cause. But if smoking cessation was successful on the development of lung cancer, we know the more you smoke, the higher the risk of lung cancer. African Americans have a higher risk of lung cancer if they smoke half as much as Caucasians. In the Iowa Women's Study, women who quit smoking, looking at adenocarcinomas, by 10 years, the risk had the biggest drop, but the risk was still 3-fold higher by 3 decades afterwards. And this is a recent study from the United Kingdom, and just look at the age at stopping smoking. Under the age of 30, if a person smokes and they can stop under the age of 30, their risk is very, very close to never smoking. But if they wait till 40, if they wait till 50, this is where a great impact and a great focus on tobacco cessation could accomplish a great deal in reducing the development of lung cancer. Well, what if you have lung cancer? Well, the horse is already out of the barn. Why really bother? It doesn't matter now. Well, tobacco smoking will interfere with chemotherapy. It will interfere with radiation therapy. And this is a meta-analysis, and just focus on the adjusted all-cause mortality. It's 2 times higher for those that continue to smoke. A second primary adjusted is twice as high, and the recurrence is twice as high. at every point in time, at any time, smoking cessation will reduce the risk of lung cancer, it will reduce the recurrence of lung cancer, and it will lessen the deaths from lung cancer. Two beautiful fields. Two beautiful fields. Both are addictive. Both kill people. Both are supported by their respective governments in the name of the economy. And it is an individual choice. Whoever chooses this field or that field, it is an individual choice. More than 100,000 people die annually as a result of the Afghan poppy fields. More than 440,000 people die annually from tobacco-related deaths in America. Are not the tobacco fields of America far worse than the Afghan poppy fields? Second is chemoprevention. The response is, I want a pill. The whole process and concept of chemoprevention is based upon a stepwise development of cancer, and this happens to be squamous cell lung cancer, where you go normal, hyperplasia, metaplasia, dysplasia, and then you develop the cancer. And it's really accumulation of genetic hits. Now, even at dysplasia, 50% of the time that can regress spontaneously. The goal is you do something, you interject here to prevent this progression. Looking at the deaths, looking at the benefit of chemopreventive pills. Beta carotene, no. Vitamin E, no. Selenium, no. Aspirin, maybe in women if they take aspirin for more than 5 days, reducing adenocarcinomas. Iloprost and oral prostacycline and Celebrex maybe has some surrogate biomarkers, not proven that it really will prevent lung cancer. And metformin in diabetics will clearly lessen the risk of lung cancer. But we want tamoxifen because that prevents breast cancer. Well, the only thing tamoxifen does is prevent ER-positive breast cancer. It doesn't prevent triple-negative breast cancer or HER2-positive lung cancer. There's not going to be a single pill that's going to prevent all lung cancers because there's such heterogeneity. This is a study from Milan, Italy. It was a lung cancer screening project in smokers, and they looked at the incidence of lung cancers based upon a Mediterranean diet. Now, the Mediterranean diet is fruits, vegetables, grains, nuts, olive oil, fish, white meats, minimal red meat, tea, and you get 2 glasses of wine a day. These are smokers. Based upon they got a certain number of points. The more they adhere to the Mediterranean diet across the board, they got these points. If not, nothing if in the middle. But wow, if there was strict adherence, not halfway adherence, these are smokers, a tremendous decrease in lung cancer. Who has the willpower to give up red meat? I don't, because I think I'm invincible and I'm not going to get lung cancer, so why does that include me? But this is something that tangibly is real. And it is something that this is so real, but do we really do that? The screening of lung cancer. Dr. Bowling talked about that a couple weeks ago, the screening of lung cancer. Do you believe it? Do you really believe it? That it's really going to make a difference? Well, here it is. Reduce lung cancer deaths by 20% with low-dose chest CT screening compared to chest x-rays, which is an arguable point that is some benefit. Published in New England Journal of Medicine. Here it is, right on par with mammography reducing breast cancer deaths. Right on par with colonoscopy reducing colorectal cancer deaths. Just a little below pap smear reducing cervical cancer deaths. It is very, very real. And you know what? Lung cancer screening, nothing gets smashed. There's no prep, nothing gets prodded. There are no stirrups. You hold your breath and you can keep your cigarettes in your front pocket. This is the outcome of screen-detected lung cancers. Screen-detected, 92%. There's some suggestion if lung cancer screening is compared to nothing, not chest x-ray, because that will increase stage 1 from 15-20% up to 50%, that it may reduce it by 2/3, which would be 100,000 less deaths in lung cancer. And maybe you do it for 3 years and then you can wait. A problem is this big question, well, who? You know, come on, get real. Who are you going to screen for lung cancer? We can't screen everybody. The task force are accepting it at face value. Those over the age of 55, if you smoke more than 30 years, yes, it fits you, it doesn't fit anybody else. Who in this room does not recommend to a woman over the age of 50, and will ignore the Canadian study, that was wrong 25 years ago, it's just as wrong today. Oh, any woman over the age of 50, do you separate out? You get mammograms, you don't. Well, that's women, that's just one gender. Well, what about colorectal cancer? Who over the age of 50 is not recommended because of a survival benefit to get a colonoscopy? Doesn't matter, it's across the board, both genders. Well, one colonoscopy every 10 years, well, what does a colonoscopy cost when you factor in everything? Probably worth 10 mammograms, if not more, and 10 low-dose CTs if it's done right. Well, what about the false positives? If you follow a protocol, the false positives are going to be minimal. And if you have the tools to deal with things, as we do here, it'll be very minimal. Certainly family history is very important. It's certainly all sorts of risks. Ultimately, the denominator will be decreased. So it will be a huge thing. But do we really believe it? Because why bother? It's really not going to matter. Well, this is just looking at this natural history of stage 1 lung cancer. And stage 1 median survival is right at about 15 months. And remember, 15 months, that's the 50th person out of 100. The 5-year mark, it's 7%. There are not any, a little clear, 15 months, 7%. And remember this curve. There are not any indolent lung cancers because 93% of people will be dead at 5 years if the lung cancer is not treated. The ground glass opacities are a whole different bird. Those cannot be lumped together and well, this is indolent. It's not stage 1 lung cancer for very long. By a little over a year, half the individuals are dead. But okay, why bother? Because they're going to die of something else. And this is a slide courtesy of Dr. Bowling. And this is looking in the COPD population, the predictors of mortality. If you just look at FEV1, greater than 50%, less than 35%, well, okay, median survival is 44 months at the 5-year mark. Boy, it's well over 40%. That's radically different than that curve. Well, let's just look at something a little better, the Bode index. FEV1, walking in 6 minutes, a dyspnea scale, and is there any pulmonary cachexia or not. Even if you're worse, even if you're in the highest category, the median survival is still 3+ years, and still 20% are alive at the 5-year mark. Still far better than that curve. No, you're not going to die of your emphysema. There's no way to predict that. Now, it's clear. You can walk in the room and make a clinical judgment, but across the board, you're going to die of your lung cancer. Well, the treatment. The treatment of lung cancer, there's been a lot of advances. It is very complex and complicated. It is no question it is best done within a multidisciplinary clinic. And at the end of my talk, Dr. Bowling will give just some data from our thoracic oncology clinic that's very intriguing and very exciting. Excluding carcinoids, which are truly lung cancer, and a typical carcinoid is just as bad as a squamous cell, an adenocarcinoma, a small cell. There are three different lung cancers: squamous cell, by gene expression profile, and by what's felt to be the cancer-initiating cell. And then there's small cell, neuroepithelial body, and then usually peripheral in the TTF1 positive terminal respiratory unit at the bronchoalveolar duct junction. Large cell is either one of three of those. And stage for stage, the treatment outcome mirrors each. It used to be, to treat any cancer, to treat lung cancer, you asked two questions. What is it and where is it? And that guided how you treat it. But now it's different. And certainly in lung cancer, you need to know where you want to end up. If you want to end up here, you know these are the steps you have to do to aim and try to get there. If you want to end up here, you can just do a very, very simple step. And in our Thoracic Oncology case conference, and we used to see 4 to 6 new ones every week. We meet every Thursday for 2 hours from noon to 2 o'clock. It was 2.5 hours yesterday. Last week, 10 new ones. This week, 8 new ones. All we discuss on every patient is where do we want to end up. Once we decide that, then we develop the steps to get there. And it used to be you really didn't need to biopsy anything, but now you need to know what to biopsy. And you have to tell a pathologist what to do with the biopsy. There's no such thing as non-small cell lung cancer. You have to know what to biopsy, and you have to tell a pathologist what you want from the biopsy. And Dr. Boley and I, and Gina Murray, and Dr. Benoit, we spend a lot of time on that, and Mark just submitted a paper, just our programmatic approach on that. And yes, that is going to take more knowledge from internists, but it's also going to take earlier input and consultation from the oncologist. The answer, don't call me till you get the tissue, no longer suffices to provide the best oncologic care. And you have to prove it if it's going to make a difference. You just cannot assume. We see multiple second opinions that everybody just assumed something and a curative window was closed. And only a pathologist can make a diagnosis of cancer. Let me say that again. Only a pathologist can make a diagnosis of cancer. A radiologist cannot. And everybody, just repeat after me, an X-ray, louder, an X-ray cannot make a diagnosis of cancer. An X-ray cannot make a diagnosis of cancer. Stage 1, okay, that's good. That's good. But in stage 1 lung cancer, 1 in 3 still die. In one of the papers that Mark and I just submitted, one of the reviewer commented, where did I get this data? Well, stage 1A is 73% 5-year survival. Stage 1B is 58%. That sort of split the difference. That's 1 in 3. So stage 1 lung cancer is still not a good thing. Screen detected is, but symptom or even serendipitous is not. Stage 1 lung cancer surgery is still the foundation. Surgery will be able to remove all the stem cells, will provide full pathologic staging, even nuances of visceral pleural invasion, lymphovascular space invasion. Will be able to stage the mediastinum, and then you will know who needs adjuvant chemotherapy. We're very, very fortunate here. In addition to Gamma Knife, we also have CyberKnife. And Mark will go over some of our CyberKnife numbers. And this is the CyberKnife machine. And it is a way to give very local ablative radiation therapy. It's usually 140 arcs. It usually takes 45 minutes per treatment. It's usually 5 treatments. There's variations on that. And it just pinpoint what the radiologist has drawn is what the cancer. It doesn't stage anything. There's been attempts to compare CyberKnife and surgery. Those studies are never going anywhere, just like radical prostatectomy versus radiation never went anywhere. We tend to treat patients who are not surgical candidates. Our programmatic approach is still surgery is the gold standard. We've treated 190 stage 1 lung cancers with the CyberKnife. And when we first started this, it was always a shock because it used to be. We were all used to the external beam radiation being very linear and retracted. But the CyberKnife gave a rounded area that was misinterpreted by radiologists initially as well. There's progressing cancer and even caused some consternation among our program. And the bigger the area, the more that was. And these things right here, it's a little hard to see. These gold bars are the fiducials that Mark will put in with navigation bronchoscopy. And again, his data will be incredibly intriguing. And the reason is, if you're lying there for 45 minutes, you have to breathe. When you breathe, the lungs go up and down. There's a 2+ sonometer variation. The computer, the robot is just focused on where those fiducials are so that every dose, whether you're turned upside down and spinning, is just going to be on where the tumor is. And unique, and it's very unique, most radiation is immunosuppressive. Now, CyberKnife is just sort of the Coca-Cola brand of stereotactic radiosurgery. There's a variety of other machines that have different names. But it's ablative radiation. And its therapeutic effects require CD8, and it will increase CD8 via dendritic cell activation. In essence, ablative radiation, CyberKnife, gamma knife, does not suppress the immune system. It actually stimulates it. And there can be this abscopal effect. Abscopus is just away from the tumor. If the ablative radiation is stimulating the immune system, you may be able to see a systemic benefit. And certainly in melanoma, that is clear. It's now been reported even in lung cancer. And we'll show you some of our oligometastatic data that has a strong signal of suggestion that that is occurring, and now it needs to be exploited. Stage 2 lung cancer, usually in one disease, meaning hilar. Gamma knife does not suffice because gamma knife cannot treat things centrally. It has to be surgery. Then we argue about who to give the adjuvant chemotherapy afterwards. Do we call it neoadjuvant and give it before? We argue about that. But what may be best, and it's what we discussed in our program, is these patients really need preoperative chemo and radiation because this is just looking at local and distant failures. And in one would be stage 2 disease. Local failure is dark, distant failure is less. So the local failure risk, and this is first failure, the local failure risk as first failure is higher than the distant. And if you just think for a split second, you realize if you have persistent disease, a local failure, yeah, you're going to end up, unless that can be caught and managed, with distant disease. So the real effort in stage 2 disease really needs to be to more aggressively achieve local control. Well, adjuvant chemotherapy. Adding chemotherapy to assumedly treat the micrometastatic disease. Everything's been pathologically resected, but you know there's circulating cells. We think that's how it works. What about that? Well, it's still 1 in 3 die of stage 1 and 1A disease. We don't recommend adjuvant chemotherapy. Okay. For medical oncologists, this was a seminal, exciting piece of information because of this. In 1995, this was 0.08, but 2003 at ASCO, published in the New England Journal of Medicine 2004, a p-value of less than 0.03 in a population of 2,000 patients with resected stage 1, 2, 3A, dominantly 2 and 3A. Now, a breast cancer study would get 3,000 patients for this very quickly, but this was huge in the lung cancer world. And a hazard ratio of 0.86. So, an absolute benefit of 4.1%. And you can see the laser go between it. And if you didn't pee in your pants when I started, this is where most people will start laughing again. You've got to be kidding. You're treating 100 patients to cure 4? We all knew we all knew you oncologists never told the patients the truth, that they were going to die. Well, yes, we do every day, all the time, room to room. Now we know you lie to them. You tell them that if they get this chemotherapy, that they're going to have a higher chance of being cured. Well, you treat 100 to benefit 4. But this isn't what is happening. Nobody has, and this is 45%, 41%. Nobody has a 45% chance of being cured. Nobody has a 41% chance of being cured. They have either as 100% or 0%. And that's what these curves are made up of. And here's what's happening. And this is just data from the NCI Canada in one of their adjuvant chemotherapy trials. They developed a 15 gene expression signature, gene expression profile for prognosis. And as you can see, the patients, you're either a 90+% cure or 0%. So every Kaplan-Meier curve, it's patients at 100%, patients at 0%. And either you're here or you're there. You can't be at 45%. We just don't know that. Now, 3 years ago, all of this stalled. This is not commercially available yet because of the Duke Cancer Center, the Anil Podi fraud. They had to retract 12 papers that were fraudulent, and things were right on the cusp to being able to have this prognostic and even predictive information. So this is if you got nothing. Well, you did great or you did poor. This is when they applied it to chemotherapy. When they looked at the high-risk patients, you were going to do poor, but if you got chemotherapy, you cured 50. You didn't cure 4. You treated 100 to cure 50. If you know you're going to recur, there's a tremendous benefit of adjuvant chemotherapy. And you throw the kitchen sink at that. This is even more sobering. What if you were low risk? Observation, chemotherapy. If you get chemotherapy, and it is cisplatin, and there's a lot of endothelial cell cardiovascular toxicities, Harry, that's what this is, you're killing people. So you have to tell the patient, if you don't need it, I'm going to kill, if I treat 100, I'm going to kill 20. That's what this is really saying. This is exciting. This is frightening. We don't have that information yet. So all we do, we learn from groups, but we treat individuals, and the benefit comes to the individuals, not purely within the group. We need to get to the point where we know prognostically and predictably it's going to turn everything upside down of who not to treat and who to treat. What about stage 3? And stage 3 is when the lymph nodes in the mediastinum are involved. Is it surgically resectable is the first question. Is it lobectomy or pneumonectomy is the second question. And is the patient medically operable? And in my opinion, I honestly have to say that only a thoracic surgeon can answer those questions. An internist can't, a pulmonologist really can't, and as a thoracic medical oncologist, I cannot. I think I know. I sheepishly ask our surgeon, was this going to be a lobectomy, right? And then sometimes, no, that's a stupid question, Walker. It's going to be a pneumonectomy, because we don't think as surgeons do, and only they can decide what's going on. And that's the crux of a multidisciplinary program. You have to have every player there right from the get-go so you know where you're going to end up. This was another seminal paper study looking at chemo and radiation versus chemoradiation and surgery. It was known that chemoradiation is better than radiation. It was known surgery and chemotherapy is better than surgery alone. It was sort of known by extrapolation, chemo and radiation is equal to surgery and chemotherapy. But what about if you go to that third modality? And the patients who got chemo and radiation, if you add the surgery, you doubled the 5-year survival. Now, this was only in lobectomy patients because pneumonectomy in the study had a 27% early mortality. Why and how? And that's where the thinking really comes into play. And this is just looking at the patients who went to surgery, pathologic CR. 18% had a pathologic CR. 18%. There's no way you can tell that. Even a complete metabolic response in a PET does not translate into 100% of a pathologic CR. It's probably 75, 80%. But what the chemo and radiation also did was cleared out the lymph nodes, because these were node positive patients, N2. So another 28%. So 18% pathologic CR, YP T0N0, 46% YP N0. And then if you go back, okay, we can't add 46% of this, but if you add about 2/3, 70% of those that are YP N0 can be cured. The paradigm is, when the lymph nodes are involved, chemo and radiation, the purpose of chemo and radiation is that local regional control. Because all surgery can do is stage the mediastinum. It's just sort of cherry picking. But chemotherapy and radiation treats. Now there's some systemic effect because local control translates into survival. But the surgery is still the best thing there is, or you can argue CyberKnife, to ablate the stem cells. So it's chemo and radiation to get the distant and the local regional, but then surgery is needed to get the concentration of stem cells in the primary. Now this is with 45 gray radiation. We had a programmatic discussion and review, and we bumped our radiation up to 60, 66, and our data is 91% clearance of the N2 nodes with more aggressive radiation and more chemotherapy. And that's a step forward, but that only occurs by thinking. Now definitive chemo and radiation. This is for inoperable, unresectable stage 3. They can't have surgery. And then we'll talk about guidelines. The NCCN Guidelines, the design was that we're going to set at least we're going to set the floor. So the general community oncologist who see 3 lung cancers a year, as opposed to our program pretty much seeing 3 an hour in clinic days, know sort of what they should do. You don't really have to think. All you have to do is look in the guidelines. And unfortunately, the guidelines, the National Comprehensive Cancer Network, it's sort of the original 13 of the NCC and NCI designated cancer centers that are this. They haven't let the other 30, the subsequent, sort of like the founding colonies not letting the rest of the states have any say-so in anything. So it's pretty much a good old boy opinion. Here's my opinion of the NCCN Guidelines. And I try to teach our fellows, yeah, you have to know the guidelines, but you have to think and treat beyond. And the problem with the guideline is there's absolutely no thinking. And what we think determines what we do. All you have to do is look up something, oh, by golly, I'm doing okay. But you don't think, and then you realize, well, you really don't have to think. All you have to do is the guidelines. And then you feel like if you do think, maybe I shouldn't be thinking, maybe I should just be doing the guidelines. Lung cancer is very complex and complicated, and it takes, you have to always think, because the outcomes are pretty poor. Plus, NCCN guidelines are not evidence-based. In their category, level 1 is evidence-based. 2A is the opinions they like. 2B are the phase 2 studies opinions they don't like. So it is not evidence-based at all. It is purely opinion-based. And here's an example of NCCN guidelines. Okay, 3B. Okay, now got a PET pulmonary functions. Okay, okay, brain MR. Okay, now that's how you tell all the internists. You know, if you have lung cancer, you get a brain MR. A CT doesn't suffice because I'm an oncologist and I know that. And by golly, I can check that off. And then, okay, mediastinum, we'll do that. We'll do that. Well, let's do it's a left AP window node. Let's have Dr. Bowling do an EBUS. Well, there's the aorta there. Now, Dr. Bowling is very used to. We have another bleeder. He's very. We have a bleeder here. He's very used to hearing that. But you have to know what the stage, and you want to know where you end up. Okay, N3 negative, see initial. N3 positive, definitive concurrent chemoradiation, category 1. It says definitive concurrent, category 1. Metastatic, it just says solitary. Well, then you look on what chemotherapy you're going to use. Well, they still put sequential here, even though they recommend concurrent. Okay, cisplatin etoposide, that's 5 days in a row. Cis vinblasting, nobody likes vinblasting anymore, just in Hodgkin's disease. And then, okay, carbapenem, okay, boy, this is low-dose chemotherapy, no toxicities. You can do it. By golly, I'm following NCCN guidelines. You can dictate that in your note. I'm going to give weekly low-dose paclitaxel and carboplatin because the guideline says you can. Well, here's the outcome with weekly doses taxol carbo. 3-year, 15%. If you use even full-dose cisplatin etoposide, 3 years is going to be 27%. So the NCCN guidelines gives you an option that's half as good as another option. So if you use weekly taxol carbo, you're telling your patient, I'm using something that's half as good as something else. Well, no, the guidelines presented that it's all the same, and you don't want to think that because you must be thinking wrong. Well, we don't follow NCCN guidelines. This is our data of over 40 patients with inoperable stage 3. We use cisplatin or irinotecan. And we're at 30 months at 38%. Now, we need to go another 6 months of follow-up to see if this holds or falls down, but maybe it's beginning to flatten here. But, okay, if we're at this is a step, but there's probably a ceiling. And the signals are we need to do better, and we're already in the process of doing developing a protocol, more sequential, more aggressive response-based chemotherapy, and using CyberKnife to consolidate the primary because there's not a surgical candidate that Dr. Roseman from UNC and I have talked to Tufts, talked to Rod Brown, he's talking to Wake Forest, he's already talked to UNC and Mark Jasinski up at Pittsburgh, and that will be developed and run from here to try to push this up because of thinking, not just retreating to doing. Well, metastatic lung cancer. You say metastatic to an individual, okay, nothing happens, they sort of, what? The boy, you say stage 4. Then that's when the tears really flow. Then they ask, well, how many stages are there? Well, there's 4. Can it be cured? This is just a concept that's very, very important to the thinking, and it's still a hypothesis of the migrating cancer stem cell. So from the primary tumor, the stem cells will migrate to the metastatic site, and then there's even migrating stem cells there. So you have to eradicate everything if you're going to cure a stage 4 lung cancer. Now, there are limits to that, but this is an example in adrenal mets. 20% are cured. And this is a very telling slide in solitary brain mets looking at the impact of thoracic therapy on survival. You have to treat everything. If you treat the metastatic site, but you do not definitively treat the primary, nothing's going to happen because the stem cells are going to be in this never-ending metastatic cascade. So you have to have definitive treatment to all sites of disease. And this is just from MD Anderson's experience of looking at, in the metastatic setting, of treating the primary. And if you think it makes sense. This is one of our patients diagnosed in May of 2011. And we knew the what. It was a TTF1 positive lung adenocarcinoma. We knew the where. Presented a symptomatic solitary brain met. There was the primary. But had N3 nodal multiple station disease and had a solitary adrenal met. And then we discussed where we wanted to end up. And part of that, you ignore a lot of things. And what we did, right now, let's just ignore everything else. What would we do here? Resect it and gamma knife the bed, okay? Ignore all this, what would we do here? It has to be definitive CRT. Ignore everything else, what would we do here? We would either resect it or CyberKnife. And had resection gamma knife, had CRT, had that surgically removed. About a year and a half later, and all of this is the edema, developed this, and this was a mixture of some recurrent tumor and radiation necrosis, confirmed on brain PET imaging. So Stuart Lee re-resected that. We did not re-gamma knife the bed because more radiation necrosis. And here, roughly a year ago, she developed this high subdigastric node. Was it a second primary? No, it was a TTF1 metastatic adenocarcinoma. Had that resected, then had more CRT here. And here she is, and this can be updated to January. And all of this is you cough, you get some laryngeal uptake, and all this is just brown uptake. So she's NED. Now, you can't give up. You have to keep at it. And this patient never was in the hospital. And that's another big divergence of our world. Because Dr. Al-Jamali and I, in our clinics, we'll see 100 patients a week with lung cancer and other thoracic malignancies that are either on active treatment or in follow-up. The lung cancer world in the hospital is radically different because they're symptomatic. That's why they're in the hospital. This patient never went in the hospital, and she's younger than me, and more patients are younger than me. And here's another individual, May to September 2003, also updated January, presented with this primary, 1, 2, 3, 4, 5 pleural deposits, and this uptake here. Now, this actually was biopsy negative. She had chemotherapy, had a lobectomy, mediastinal dissection, and the disease in the pleura was R0 resected. And she's had a recurrence, another isolated pleural met and a subcarinal node, had a CyberKnife to that, and had to have some more CRT to that. And right now she's NED. The treatment paradigm of metastatic lung cancer is radically different. It used to be just systemic chemotherapy, but now you need to treat the primary. If you have ablative radiation, those that haven't responded, you treat those sites, and you may get an abscopal effect, and you can maintain, and then there's the concept of oligoprogression. And just want to spend a little bit on this slide. And this is our data of 53 patients with lung cancer with oligometastatic presentation treated definitively with CRT to the primary and ablative radiation to the metastatic sites. And one of our fellows has submitted to ASCO and working on one of our 9 fellow submissions to ASCO, and then as a manuscript. The blue, this one, are the adenocarcinomas. This one is the non-adenocarcinomas, but the one in the middle is sort of the stage 3. That was that curve I showed. 2 things. By golly, if you had an oligometastatic adenocarcinoma, you did better than if you just had stage 3. Now, the stage 3 data is right now still a mixture of adenosquamous. But if you had non-adeno, you did nothing. But otherwise, it's 25 months and a 30% 3-year survival. But what's striking here, whether squamous or adeno, it separates early, and adeno separates and stays. And our hypothesis is that this is likely the abscopal effect from the ablative radiation. It sort of separates it, but now we need to do something, not chemotherapy, but we need to manipulate the immune system to try to drive that up. In maintenance chemotherapy, only one chemotherapy agent has worked, all others have failed, and the reason it worked was not because of the cytotoxic effects, but it was suggested here. A lymphocyst, gem cyst, chemo stopped here, but why did the curve separate way out here? Because it actually affected this enzyme, and then it was an mTOR inhibitor, and this is just the MD Anderson data that if you have upregulated AMPK, you have a slower tumor biology. And in maintenance chemotherapy, the goal is slow the tumor biology. And everything is heterogeneous. This is just looking at this curve. This is erlotinib, and now you're resistant to that, but you slowed down the tumor biology even with the resistance. I want to move a little quickly just so make sure Mark has time. In the past decade, there's been a big shift to be able to molecular subtype adenocarcinomas, now the squamous genome, now small cell, and even squamous. We now have sort of 4 different types. But if you have a driver mutation that is actionable, you can give a pill. That's great. And these are the pills we have. Boy, you get a great outcome. All EGFR mutations are not the same. But this is where it's exciting. But the more you know and the more you realize you don't know, and you don't know until you know, and you will not know if you do not think. Because here, EGFR mutated lung cancer, you get afatinib, which is the newest kid on the block compared to chemotherapy. Progression-free survival is far superior. But yet, overall survival is the same. Well, okay, that means those that got chemo first ended up getting the TKI. That's crossover, that's fair. But why the other way? Why did you lose all of this progression-free survival? Well, we're taught, and nobody knows for sure, there's a variety of hypotheses, we're taught if a cancer progresses, you stop that treatment and change. But if you're slowing the tumor biology, you don't stop. And when these patients stop, one hypothesis is there was a rebound growth. That's why you lost all of that benefit. There may be some manipulation of the immune system that has an impact. I'm just going to skip over here. And not, well, sexy may be priceless, but not everything is pricey or sexy. This is just looking at metastatic lung cancer, and it's published in the New England Journal of Medicine. The palliative care really was symptom control. There's 150 plus patients. They got standard treatment, but they really had symptom control, a focused symptom control by somebody who focused on that. At the 10-month mark, things separated. By golly, if you had symptom control, have you ever seen a chemotherapy agent in metastatic lung cancer do that? Never. It's really not clear why. We know symptoms are associated with inflammation. We know Alberto Mantovani and Jeffrey Pollard have put together over the past decade this hypothesis that the smoldering microenvironment inflammation with macrophages will stimulate cell proliferation, invasion, motility, the metastatic cascade, angiogenesis, and immune suppression. So it may reflect is inflammation being shut down. And one of the studies that is almost ready for, it is ready for submission, that we're going to do in our thoracic oncology program. We have an outstanding symptom management PharmD, Jeff Stroud. We are going to, every patient we know, this Veristrat proteomic study is a bad prognostic indicator, or it can be a good prognostic indicator, and it's all inflammatory protein. So every patient with metastatic lung cancer is going to be fully treated. Jeff's going to see symptom control, and we're going to measure 3 points in time, the Veristrat proteomic study. The company is going to provide that for us to see if this is because of inflammation control. That is our hypothesis as why you're seeing something that's really astounding. And another thing, beta blockers in stage 3 lung cancer. If you get a beta blocker, you do much better than if you don't get a beta blocker. Now, the sympathetic nervous system, there's also signal transduction, a lot of transcription processes going on for that same process as part of the inflammation. But we all think lung cancer, why beta blockers? But beta blockers, these are stage 3 lung cancers. Those who got a beta blocker did much, much better. If one thing you remember today, and it may be the ultimate answer, this is just looking at federal research funding per death. Okay, lung cancer, the most deaths, it's pretty much this level. But by golly, when more money's put into it, whether this is the correlation, but the more money put into it, the less deaths there are. Curing and controlling lung cancer, can it be done? In our thoracic oncology program, we spend a lot of time, Mark and I are doing this every day, all the time, trying to focus on this. And in our opinion, yes, it can be done. It will take more research dollars, but just a societal and healthcare acceptance and focusing on tobacco cessation and implementation of lung cancer screening. Thinking beyond the shame, blame, despair of lung cancer, and thinking beyond the diagnostic therapeutic nihilism in lung cancer will achieve this. Now, the nuances of treating lung cancer are very, very broad, deep. It's layer after layer. It's complex. It can only be done in a multidisciplinary clinic because you have to think and do beyond, you have to think and do together. And we're very fortunate because we have a very, very good thoracic oncology team. Curing and controlling lung cancer, can it be done? It's not done yet, but yes, it can be done. And in transition to Mark, just want to invite everybody. Our 4th annual Coach Rock Golf Classic is Monday, May 5th. It supports exclusively the Leo Jenkins Cancer Center, Coach Rock Rogaman Cancer Research Fund. He was the defensive line coach for Skip. We have $250,000 already in that fund that will be utilized for our institutional trials. And it's Coach Rock's approach to coaching, and he died with a lymphoma. You go toe to toe, you do not flinch, you do not back down. Mark.
It's thank you. Well, I tell you, every time I have the honor of being able to hear Dr. Walker talk every day on Thursday, and I'm just surprised that we got through this without you showing a funny picture of me, because usually I get made fun of somewhere around there.
I skirted the edge.
Yeah, okay. Last time I was here, I told you guys that I didn't have any data to kind of show what I was talking about as far as what we've done from our thoracic oncology program. So I went back and actually started looking at some databases and got some preliminary data just to kind of show you some things. I chose 2010 to 13 because it was just an easy cutoff, but you can see that, and I use E&B because this was basically going to be data from a manuscript we're preparing right now to look at the impact of navigational bronchoscopy on a multidisciplinary thoracic program. What it really is saying is about the multidisciplinary program. It's not necessarily about E&B itself. It's how that tool fits into our program. And Dr. Walker has very eloquently made the argument, much better than I can, but there's a huge cultural change, and that's what we're trying to get through, is that it's no longer don't call oncology till I have tissue. We really need to know, for us that get tissue, what the end result's going to be, because it makes a huge difference when we're in there getting the tissue, how we do it and how we approach it. It's completely 100% changed the way that I was taught to biopsy and sample these patients. It's completely flipped around. If we don't start doing that, the patients will suffer more procedures and more complications and probably more expense. And I can't tell you how many times I have to redo procedures, not because anybody did anything wrong, it's just because we don't have everything that we need to get to that end result. Where it can be done in one shot. We've shown that. I'm going to show you, if we know up front, and we're called up front, and we think about it up front. So you can just see there's been a huge increase, well, fairly big increase in patients, total patients, and these are all thoracic patients, not just lung cancer. Some of them may be esophageal. This is showing you that basically the number of non-small cell lung cases by stage before and after the introduction of navigational bronchoscopy. And again, what this is showing is I don't necessarily think, the big thing is look at the stage 1 and stage 2s have actually changed quite a bit compared to the 3 and 4, so they've decreased where these have increased. I don't think that navigational bronchoscopy is necessarily downstage people or show that we've got more stage 1s and 3s and 4s that we're creating them or we miss stage folks. I think what it's showing, and this is going to correlate very well with the CyberKnife data, that we're aggressively identifying these. We are aggressively going after nodules and small lesions that we didn't before because we have the capability of doing it, and we're aggressively treating these patients that cannot get surgery. Because in a minute I'm going to show you the CyberKnife data, and the CyberKnife data, who gets CyberKnife? Folks who cannot have surgery. And a lot of our folks can't. So I think the thing that I want you to put in your mind about this is without screening. We haven't even started screening. This is the result you want to see with a screening program, right? You want to see tons of 1s and 2s and very little 3s and 4s, because if anything, most of the time Dr. Walker's talks go way over my head. And I have to have him really get them down to me to understand. And the one thing that I got back from this is that we can treat any type of lung cancer, but the earlier you get it, the better chance you've got for a complete cure. But it doesn't mean you can't be cured if it is, I'm going to use the term, even though I'll get something thrown at me, advanced lung cancer. But this is what you want to see with screening, and that's my next pledge to you. We're going to start it here. This is just showing there's been a 20% decrease in thoracic oncology clinic patients, at least the ones we're seeing, in 3s and 4s, but a 73% increase in stage 1 and stage 2s. Number of lung resections. Since we've implemented E&B, we've also added a thoracic surgeon. You have to take that into account. But we've seen a 22% increase in thoracic cases. I think this number is actually higher, but because I think our data is not fully complete. But clearly we're seeing that change. Why? Because I think our thoracic program is firing on all pistons. I think we're all on the same page. We have a programmatic approach, and we have very aggressive surgeons. Matter of fact, I'll say after training at Wake Forest and being at University of Mississippi, I have never seen more aggressive therapy anywhere, including Wake Forest, which is NIH-sponsored cancer center and all this other stuff. we actually go after lung cancer much more aggressively here than any place else I've ever been, and that includes surgery. I've never seen as much lung surgery here. This is actually one of the really interesting slides, and this will go back to that stage 1 and stage 2, how those have gone up and the 3 and 4s have gone down. This is before E&B, and this is the number of CyberKnife cases. So these are the total number of cases here, and I don't even really care if you see this stuff, but this is for the bronchoscopy stuff. But what these two things are showing is that the Carolina Blue here, which I think did beat Duke yesterday, didn't they? Just by the way, thought I'd throw that in. Is actually the number of fiducials that were placed by bronchoscopy, and that's what we do. So we go in and we put these little gold markers in and around the lesions. This is the number that's placed by interventional radiology. It does a good job. Now this goes back to our programmatic approach. Why do we really care about this? Because our radiation oncologists want lots of fiducials. They at least want 5. So if an interventional radiologist is putting in a fiducial, they have to pass through the lung 5 times. That leads to a higher rate of iatrogenic pneumothoraces, maybe more admissions, more chest tubes, more problems. If we can do it bronchoscopically, we have a 3% chance for a pneumothorax, whereas in radiology it's about a 20 to 35% pneumothorax, depending on the lesion. So before E&B, we didn't really have a lot of that capability, and you can see here that as we got navigational bronchoscopy, obviously the interventional radiology stuff dropped off, ours went up, but look at the number of cases, how much they've shot up, just in 2 years. And we're probably doing, and I'll argue to say, I know from a fact, at least from the company that we use, the fiducials, which is the most popular fiducial out there called the Cobra, we're doing more of those than anybody in the country, they tell us. So this is amazing. And remember, who gets CyberKnife? Folks who can't tolerate the surgery. These are folks who might, what would they have happened to them before that, do you think, Dr. Walker? Watchful?
Watch, wait, die.
Okay. And this is also really interesting as we talk about the age of, obviously, and it should be in the forefront of all of our thoughts, of how to decrease risk, decrease hospitalization, decrease, and actually being cost effective. And this is kind of a duh thing, and it's not anyone's fault, it's just the nature of the procedure. But before E&B, when you place fiducials, there was a 22% rate of a pneumothorax. Now we're down to 4%. Patients admitted, being observed, had to be watched, how many chest tubes are put in. Again, it's showing that we have the tools and capability to provide this care. If you look at some data that's out there, because I wanted to know, are we that unique? What's really going on? How do we compare to things that are out there? There's not a lot of data, and that's why I want to get this out here to show our manuscript. But out of a 281-bed community hospital, there was when they showed E&B, they saw a 25% increase in thoracic cases. And actually, this was not with E&B. This was just with the lung nodule clinic. 25% thoracic cases and a 25% increase in stereotactic radiosurgery volume. You've seen our numbers there. And this is data with E&B. This is from a physician whose name is Garwood, who I really, really admire. She is fascinating. She is actually a private pulmonologist. Convinced her partners to let her do nothing but bronchoscopy. Well, I really want to know how she did that. She does nothing but sit in the hospital and does bronchoscopies and help with the thoracic oncology. She started a thoracic oncology program, and by implementing E&D and EBUS in a 500-bed community hospital, this is right outside of Nashville, she competes directly with Vanderbilt. They did 101 new bronchoscopies, which was mostly EBUS and E&Ds. For peripheral lesions. They were able to show an increase of 31 surgery cases, 10 new chemotherapies, 86 new radiology studies, and 3 XBRT cases. They had just started CyberKnife at this time. This data is about 2 years old. I really want to see their second year's data. And this is, again, same thing we saw. It's not that much of a duh when you think about it, but they started a cancer program. They did it in a systematic way, and what did they start seeing when they went after these things? More stage 1s. And that's exactly what they showed, with a 72% increase in stage 1s compared to stage 2, 3s, and 4s. So we're on the same pathway as they are. I think we're a little bit more advanced than they are simply because our program's older, but these things work. And she has a very similar approach to exactly what we're doing. It was fascinating talking to her. I really admire her quite a bit. I'm begging her to publish her data. She says she's too busy. And I said, well, give it to me and I'll publish it and put your name on it, but give it to us. Because these are the things that really need to get out there so people can learn from. And that's basically it. This is just showing you about a nodule clinic, and basically one of the things we really need to drive home is this, is I want you to get this in your head here. And basically what it's saying is that when a patient comes in with an abnormal scan or actually is evaluated by a primary care physician, how long does it take till they actually get evaluated, seen, and their cancer treated? Look at that. 80 to 120 days. 80 to 120 days from when someone comes into an emergency department or goes to their primary care physician or whatever it may be, that they actually see that abnormal scan that turns out to be lung cancer before it's treated. My pledge to you, I've got 2 of them, next time I talk to you, and I won't do a grand round because I do this, is that we're going to start lung cancer screening here. It's the last thing I do is what we're going to do. And number 2, we're going to come back with data to show you that our process is much more efficient. From the time that the patients are seen in our clinic to when they get diagnosed. I can tell you off the cuff right now, that's about 4 business days. So once a patient is seen in Thoracic Oncology clinic and discussed up front, before we even touch them, no biopsy, I have them on the table, do a bronchoscopy or surgery within 4 to 5 business days. They are getting treated. Or they're getting CyberKnife in 2 weeks. And we're going to change that too once we show that you don't need to wait a week after fiducial placement. But this is staggering to me. And again, this is just showing you that if you increase a lung volume, a clinic in an organized way, you actually can increase how you see these folks. So that's basically it, and what I wanted to show, because I promised you I'd bring you back some data. And the big thing I want to say, and I know I'm kind of preaching to the choir, is that we're really doing a lot of amazing things here at ECU, and I'm not just talking about the Thoracic Oncology program. We do a lot of work. We work very hard. And sometimes it's hard to step back and see all the good things we're doing. There's a lot of opportunity here. I urge, encourage, and beg each and every one of you to get very passionate about something. And if you get very passionate about something here, you can really develop that. And you can make a huge difference in Eastern North Carolina. And I would argue, and my goal is not only Eastern North Carolina, but North Carolina. I want them to talk about us, not the place down the road, ever. Only in comparison to us and that we're better. And then I want to take over all of North America. Don't stop. And then I want you guys publishing. Let the world know what we do here. We do so many good things. You can do it. I'm telling you, and I expect each and every resident to submit something to Kataria Day, please. Okay, thank you.